Herkese merhaba. Bizim aylık Omuz Dirsek Cerrahisi Derneği'nin organize ettiği webinarımıza hoş geldiniz. Bu ayki konuklarımız Japonya'dan. Çok önemli omuz cerrahları ve bilim adamları Dr. Sugaya ve Dr. Mochizuki. Bugün onların sunumlarını dinleyeceğiz beraber. Konumuz parsiyel kat, yani kısmi kat rotator manşet yırtıklarında yeni konseptler. Hem anatomik hem de klinik olarak, cerrahi olarak bunları dinleyeceğiz. Ben şimdi İngilizce kendilerini tanıtacağım ve sonrasında İngilizce olarak devam edeceğiz. Sonda yine bir tartışma bölümümüz olacak. Lütfen sorularınızı bize alttaki questions and answer bölümünden ulaştırabilirsiniz. Sizlerin sorularını da yönlendirmeye çalışacağız. Şimdi İngilizceye döneceğim izninizle. Hello everybody. Welcome again Dr. Sugaya, Dr. Tomo Mochizuki. We are very happy to host you as a Turkish Shoulder and Elbow Society. On behalf of our president, Professor Mustafa Özkan, I welcome you again in our webinar. I will briefly introduce our two lecturers, our two shoulder surgeons and scientists. Hiroki Sugaya, he doesn't need any introduction, but I want briefly to introduce him. He's now currently president of Tokyo Sports and Orthopedic Clinic. He's also professor and honorary instructor of John Burns School of Medicine, University of Hawaii, and also professor of Tokyo Medical Women's University and Department of Orthopedics, Chiba University. He finished his medical faculty in 1978 and got the PhD degree in 1997. His clinical interest is mainly arthroscopic surgery for shoulder and elbow and shoulder arthroplasty. He is also member of editorial board of JSES and Journal of Clinical Sports Medicine and Japanese Shoulder of Orthopedic Surgical Technique. And he has so many lectures, and he is also invited lecturer and live surgical demonstrations in ASES, AANA, and San Diego, Nice, Annecy, Berlin, Paris, and Belgrade shoulder courses. He has so many publications, more than 100, with more than 4,000 of citations. His current H index is 28, and his current ResearchGate score is 37.19. And Tomo Mochizuki, Professor Tomoyuki Mochizuki is also from Tokyo. He is the chief and orthopedic and shoulder center of Tokyo Kita Medical Center. He's finishing his medical degree in 1996 and got the PhD degree in 2005. He was the former fellow of Professor Sugaya in 2005 in Funabashi, and also he was the international visiting fellow in Washington University, St. Louis, with Ken Yamaguchi in 2009. He got 2 awards. One is AOS Poster Award in Shoulder and Elbow Section 2007, and he was selected as a traveling CESEC Asian Fellow in Europe. He's commonly his studies is about anatomy of the shoulder and knee joint. He's also working on human and rabbit and rat mesenchymal stem cell cultures. His clinical interest is about the arthroscopic rotator cuff and Bankart repair and total shoulder replacement. He's also the team doctor of rugby football women national team. He has so many publications, more than 75, with 3,855 citations. His current H index is 32, and also ResearchGate index is 34.88. So today we will talk about the rotator cuff, and this is the main study. This is the game changer study of Sugaya and Mochizuki in JBJS 2008. And we will go and we will build our webinar on this concept. And we will talk about the first, Tomo Mochizuki will make his presentation about the anatomy of the rotator cuff and its relationship with the tear patterns. And after Professor Sugaya will talk about what we have learned from the literature and what are we standing today. And after we will discuss about the two topics, you can give your discussions and questions and answer during the presentations. Thank you very much again being with us. Dr. Tomo, can you please share your screen first and then Professor Sugaya will do it. Okay. Thank you for your attention.
Okay, can you hear me?
Yes, Dr. Tomo.
Okay, thank you very much for having me and the great web seminar.
Share your slides, please.
Okay, just a moment. Moment. We can see this. Can you see my slide?
No, not yet.
You cannot? Okay. Just a moment, please.
Yes. Don't worry. We are waiting for you.
Okay.
We have time. We don't have time. Don't worry.
Something wrong. I'm not sure what happened. Okay. Okay, just a moment, please. Okay.
Yes, we are waiting.
Okay.
Don't worry.
Okay.
Yes, perfect.
Can you show my screen? I'm so sorry.
Perfect. Your screen is yours. Thank you.
I'm very sorry. Thank you very much for having me in a great web seminar in Turkish Society and Shoulder Elbow Surgery. My topic is revisiting the anatomy of the rotator cuff and its relationship with tear patterns. I have nothing to disclose. First, I would like to introduce myself. I'm now 50 years old now, and I work in the Tokyo Kita Medical Center. It is located northern part of Tokyo. I worked with Dr. Hiroki Sugaya in 2007. I was previous fellow. So I hope you know our paper regarding femoral insertion of the supraspinatus, infraspinatus. This paper, after this paper published, more than 10 years have passed since our report. And I'm gonna introduce our study in short. This is super view of the right shoulder. The acromion was removed. You can see that in this stage, we cannot recognize the border between the supra and infra. But after removal of the overlying tissues, such as the coracohumeral ligament and fat tissues, you can see that the anterior border of the infraspinatus is a little bit thicker than the posterior part of the supraspinatus. And this tendon portion running towards the bicepsal groove. In order to clarify the tendon structure, we removed all muscle fibers from the supra and infraspinatus. So you can see that the posterior part of the supraspinatus tendon is thin and short. On the other hand, the anterior part of the infraspinatus tendon is thick and long compared with posterior part of supraspinatus. So we can easily recognize the border supra and infraspinatus. So we remove the infraspinatus along with the anterior margin of the infraspinatus. You can see that the infraspinatus occupies most area of the greater tuberosity. On the other hand, supraspinatus occupied anterior margin of the greater tuberosity. It's like a triangular shaped pattern like that. Fortunately, in 2015, Lumshudain in New Zealand reported almost same footprint as we reported. He said that infraspinatus occupies the middle facet with an extension of a lateral border of the highest facet. I'm going to show you the specimen with rotator cuff tear. This is right shoulder, superior view of the right shoulder. You can see that the rotator cuff lesion, rotator cuff tear lesion here. At a glance, this lesion involving the supraspinatus. However, we remove the posterior part of thickness portion of the tear lesion. You can see that anterior margin of the infraspinatus stop here. It means that this region occupied mainly infraspinatus. Open up the infraspinatus like that. A little bit to a lesion can be found in the supraspinatus, but this kind of rotator cuff tear mainly occupied infraspinatus. So based on our anatomic study, most of the rotator cuff tear, more than mid size of tear, can involve the infraspinatus. Based on our study, we introduced the anatomic repair of rotator cuff focusing on the infraspinatus in 2009. This kind of tear lesion occupied infraspinatus, so we're pulling medial posterior leaf of the torn lesion from posterior medial to anterior lateral, and then fixed until part of the greater tuberosity. In our study, we also reported the attachment of the capsule. We reported capsule attachment, length of capsule attachment is 4.5 millimeter on average. This result is much larger than we expected. As you know, the Clark and Harriman reported in 1992, capsule is deepest layer of rotator cuff, this region. It is thin continuous seat. Capsule seems functionally significant. However, there has been no anatomic study refers to the capsule. So we also investigated the capsule. This is a superior view of the coronal section of the left shoulder. You can see the labrum here, infraspinatus here, and the capsule here. We could easily separate it between the capsule and the tendon in this region. You can see that the capsule is thin here, tendon is thick here, but the insertion site is almost same size. This is a superior view of right shoulder. We remove the supraspinatus, infraspinatus. At this stage, you can see that the capsule is intact. And then we remove the capsule. This area surrounded white dot line is capsule attachment. We can say that capsule occupied a substantial area of the greater tuberosity. You can see that anterior margin of the greater tuberosity, capsule attachment is 3.5 millimeter, and the tendon attachment 5.6 millimeter. It's a thinnest insertion of the capsule is 3.5 millimeter. Tendon insertion is 8.1 millimeter. Between the infraspinatus and the teres minor, this area tendon insertion is very thin, but capsule insertion is very long. It's 9.1 millimeter. It means that at the thinnest point of the capsule, rotator cuff had relatively thick insertions. Where the tendinous insertion were thin, capsule had a relatively thick attachment. So capsule and tendon seems to complement each other at their insertions. This is a histological section of normal specimen without rotator cuff tear. It's 10 millimeter posterior from anterior margin of the greater tuberosity. This section, you can see the tendon, you can see the capsule. Capsular tendon is almost same size this here, but the insertion side, capsule insertion is thin and the insertion of the tendon is thick. So we also investigate glenoid attachment of the capsule. In terms of the glenoid attachment of the capsule, you can see that the anterior area of 6.7 millimeter, inferior part of 7.7 millimeter, posterior part of just around 6 millimeter. Compared with the attachment of the humeral side, glenoid side is attachment size is almost similar, around 6 millimeter. And after we remove the whole capsule, we analyze the thickness of whole capsule using micro CD. Like that. So color, red color is thick, more than 6 millimeter. Blue is thin, less than 1 millimeter. Yellow and green is medium. So you can see that the insertion side, glenoid side, both glenoid side, humeral side is yellow. It means relatively thick. On the other hand, anterior side, posterior side, and the superior side is capsule is thin. Inferior side is thick. Of course, there are some variation of the capsule thickness. This specimen is anterior part of the capsule is thick. Posterior part of the capsule is thin. This specimen, anterior part of the capsule is thin, but posterior and superior side capsule is relatively thick. So in this presentation, we are wondering what is the partial thickness of rotator cuff tear? My answer is bisal side rotator cuff involves rotator cuff tendon, of course tendon. However, articular side of rotator cuff tear can involve articular capsule. When we think of laminated lesion, delamination of rotator cuff tear, it is firstly reported by Sonavent in 2001. And also Dr. Tanaka, he's also a previous fellow of Hiro. They checked their 201 cases in ARCL. And he found that 110, almost half cases, he recognized the delamination. But delamination, a pathology of delamination is not clear. So we made a histological section of specimen with rotator cuff tear for specimen. This slide, you can see that delamination here. In the histological section, also, of course, you can see the delamination here. This deep layer is capsule or tendon. When we compare with normal specimen, you can see that the normal specimen, this is border between the tendon and capsule, and the white star is capsule. When we see that delamination specimen with rotator cuff tear, you can see the border. This is a superficial layer, this is deep layer. Honestly speaking, we don't have enough evidence, but morphologically and also histologically, deep layer must correspond to the capsule or must involve the capsule. So based on our anatomic studies, well, I'm going to introduce anatomical repair of rotator cuff with delamination. Deep layer is capsule. I believe it's capsule. So we plane this lesion from medial to lateral and fix medial margin of the related tuberosity. Superficial lesion mainly occupied infraspinatus. So this lesion pulling from posterior to anterolateral and fixed anterior margin of the related tuberosity. I reported in 2017 in arthroscopy. This is my take-home messages. Infraspinatus occupied most area of the related tuberosity, so most of rotator cuff, I think that more than medium-sized here can involve infraspinatus. Capsule is relatively thick and attaches wider area, so articular side tear can involve the capsule. And also, deep layer of delamination can be the capsule. Thank you very much for your attention.
Thank you, Dr. Tomo, for your nice presentation. We will have the questions after the after Professor Sugaya's presentation also. Please, Dr. Sugaya, can you share your slide?
Okay.
Thank you. We have now 120 participants.
Wow.
Yeah.
Okay, Kerem, can I start my lecture?
Yes, please. Thank you.
Okay, thank you very much for inviting me, actually inviting Tom and myself for this wonderful Turkish Shoulder Elbow Society meeting. It's our great pleasure to speak about our basic concept regarding rotator cuff problem. So my role of this talk is what we have learned from the literature. Where are we standing today? So this title, actually, this is this title. Kerem gave me this title, so my lecture is not so big as this title. But I'm gonna speak about the partial thickness rotator cuff tear problems based on the anatomical study. Actually, Tomo presented before. Okay, so let me introduce myself a little bit. Actually, I've been working in the Funabashi Orthopedic Hospital Sports Medicine Joint Center in the past 20 years. But last September, I opened my own new clinic in Tokyo. So this is the Tokyo Sports and Orthopedic Clinic. This is kind of, I wanna, my dream, I will make my dream come true. So that's why, in order to my dream come true, so that this is my one of the process to my dream. So once this terrible pandemic subsided, I want you to guys to visit my clinic in Tokyo. Okay, so this is the rotator cuff tear and pain symptom. We need to think about the symptom of rotator cuff tears. So everybody tends to speak about the rotator cuff. How do we fix rotator cuff tear, the surgery? But we need to look at the more important things, the rotator cuff tear and its symptom. So this is a very interesting, important study by Ken Yamaguchi. And he investigated 558 patients who complained unilateral shoulder pain. And he investigated using ultrasound on both sides. And he found that the average age of the patient who has only a tear, rotator cuff tear on the affected side was 59 years old. On the other hand, patient who had bilateral rotator cuff tears was 68 years old, and patient who didn't present any rotator cuff tears on both sides, average age was 49 years old. That means rotator cuff tears, the prevalence of rotator cuff tears increases with age, regardless of symptom. So this is another interesting study, important study. Actually, this is done by my former fellow, Dr. Yamamoto. He's working in a rural area in Japan. And he did a medical checkup in a Japanese mountainous village using ultrasound. And he found that 283 full thickness rotator cuff tears in 211 individuals, which is out of 1,366 shoulders in 683 individuals. So prevalence of rotator cuff tear, he found 20.7% in all individuals. And interestingly, 2/3 of the shoulders with rotator cuff tear did not demonstrate any symptoms. So that we need to see that we need to understand there are a lot of asymptomatic patients or patient who works in the conservative without we can remove the symptom without surgery. So the goal of treatment of rotator cuff tear patient is to remove symptom. The options of treatment include physio and also the injection shot and also the surgery. And the factors affecting rotator cuff symptoms includes inflammation and also the functional deficit like a scapular dyskinesis and also anatomical factor. So that even after controlling inflammation and a functional deficit, still patient complain the pain because of the anatomical factor, then the surgery is indicated. So what about the partial thickness tears? So does it always require surgery? No, but sometimes yes. So what about the intratendinous or articular-sided tears? Yes, but I think it's rare. I think many this kind of shoulders, partial thickness, rotator cuff tears, intratendinous, articular-sided, associated with stiffness. So that's why the main treatment is not surgical repair, but also the stiffness treatment, like a pain control. Sometimes they require cuff surgeries without rotator cuff repair. What about the bursal side tear? The conservative treatment works in many shoulders. But if the patient has associated with impingement, often requires surgery. So on both partial thickness rotator cuff tears, I think intramuscular tendon involvement is very important. So let's look at the anatomy once again. So the Tomo very nicely presented the anatomical study in his previous talk. But I want to look at supraspinatus intramuscular tendon. This insertion is extremely important for clinically very, very important. And also the Tomo and Nimura and their group investigated capsule insertions, as Tomo described, like this. They investigated the capsule insertion by removing a rotator cuff insertion like this, and then found that at the end, they found the capsular insertions very thick, especially at the area between the infraspinatus and also teres minor. So this is a posterior rotator cuff structure. This is infraspinatus tendon. This is teres minor tendon. When we look at skull, arthroscopically at this area. So the capsule between the infraspinatus and teres minor, the muscle inserts to this area, so that it is very clearly understandable when we look at the scope. So that this area is very important, clinically very important. I will describe later. So let me speak about the rotator cable concept a little bit. The rotator cable concept is proposed by the Steve Burkhardt back in 1993 in general arthroscopy. He said that the rotator cable extends from its anterior attachment into the greater tuberosity just behind the biceps tendon to its posterior attachment near the inferior border of the infraspinatus. So he called this cable as a suspension bridge. So he insists the clinical importance of this structure. And also the anterior cable inserts just behind the biceps tendon is like this, like here. And also the posterior cable inserts to the inferior border of the infraspinatus. This means exactly where the capsule, the thickest insertion area located between the infraspinatus and teres minor. But when we look at this cadaveric specimen, and also sometimes we always see rotator cuff, normal rotator cuff during the surgery. But this kind of rotator cable is not so remarkable like this picture. Okay, it looks like this, always like this. So okay, we can recognize just a little bit rotator cable like structure, and then just a little bit rotator crescent-like structure. So when we look at I found a very interesting, important study coming from Europe, and this is a humeral semicircular ligament. This is the capsular thickening when we look at from inside the joint, and this capsular thickening is very, very interesting. This divided into two layers. The superficial layer inserts to the lesser tuberosity, and also deep layer inserts to the most anterior portion of the greater tuberosity. This insertion area is exactly same as the intramuscular tendon and the supraspinatus tendon. And also when we look at the posterior side, the posterior cable insertion, this ligament, humeral semicircular ligament, inserts to the posterior portion just in between the infraspinatus and teres minor. So based on the anatomical study, and also based on the rotator cable concept, I combine these concepts together like this. So this is supraspinatus tendon insertion, and these are infraspinatus tendon and also teres minor tendon insertion. And this is anterior cable insertion. This is capsular insertion. And this is posterior cable insertion. So that's why I summarize like this, and summarize like the intramuscular tendon of the supraspinatus and the anterior cable have anatomically indistinctive structure, because at the insertion area, we cannot distinguish these two structures, okay? And the posterior cable locates between the infraspinatus and teres minor, and supplements the sternus tendon insertion area. So this structure is very important. So let me share the cases. I will share two cases. This is a 19-year-old male alpine skier. He fell on the right shoulder during ski racing. 3 months after injury, he presented complaining pain and severe catching. And the range of motion was limited to only 100 degrees when compared with the other side, 180 degrees. And also he complained severe scapular winging because of the impingement, catching. The rest of the range of motion is normal and also no pain-free. And MRI demonstrates like this. We can recognize a little bit white spot inside the tendon. This is the partial thickness tear. And this is the scalp. This is the right shoulder. When we look at from the inside joint, he had a tear just behind the biceps tendon. This is the anterior cable. And when we introduce the stick from the vessel side, there's a hole. So that's why this is a not partial thickness, this is full thickness there, but you see there's a very thick. This one is a, okay, this is the, this very, hard structure is a anterior cable. So when repair, I incorporated the anterior cable to the repair like this. And after surgery, he returned to exercise 3 months of surgery. So right after surgery, his symptom improved. So this is very, demonstrative case. The next case, 27-year-old female, and a cross-country skier fell on the left shoulder during the practice and complaining emotional loss and the weakness for 2 months. And the range of motion was restricted to 95 degrees with pain. And when compared with the 180 degree, the other side, and also external rotation also limited to 15 degrees because of pain. And this MRI shows also the white spot inside the tendon like this. And this is arthroscopic view. So this patient has tear right behind the biceps tendon. This is the anterior cable. So in this case, this is a 100% partial thickness tear. So I performed the Posterior transtendon repair. Now scoping is inside the bursa. I tied the knot from the bursa. And then once again came back to the joint. This is the after repair. Okay, so the anterior cable disruption is very interesting and very important concept. Sometimes seen in athletes, young athletes presenting partial thickness cerebrospinatus tear after trauma. And the symptoms of dramatic impingement and also weakness. And the surgical repair can remove symptoms immediately in most cases. Okay, so let's go to the Posterior. Posterior is a undersurface rotator cuff tear. This is the Steve Schneider named this region as Posterior. The partial thickness, articular-sided, cerebrospinatus, tendon avulsion. So normal Posterior region is not so problematic to me, but to me, the Posterior region sores are really big problem. So I don't know in Turkey, there's maybe no sores, but I think maybe some tennis player or some overhead athletes may demonstrate the similar symptom and the problem. So the Posterior region is sores are different. This is not cerebrospinatus. This is infraspinatus. Okay, so based on the anatomical study, the cerebrospinatus tendon inserts to the most anterior portion of the greater tuberosity, and the rest of this area between the infraspinatus and the teres minor infraspinatus and the intramuscular tendon insertion. So this area is a little bit weak. So normally for throwing athlete, the tear initiates from here. So like this, the gradual progress with time, leaving intramuscular tendon of the cerebrospinatus intact. So that's why I call this an infraspinatus problem. So the tear propagation pattern is like this, like this, like this, like this, getting bigger and bigger and expands to the posterior and also lateral. And then, normally the anterior cable remains intact. On the other hand, if the tear getting bigger, the posterior cable was involved. So how do we treat this? Of course, conservative treatment because they are throwers. So scapular function, mobility, and stability is very important. The remaining rotator cuff function is also very important, and the core and the lower extremities and the throwing mechanics. But most Posterior, this is very interesting. Most Posterior region throwers who has most throwers who has a Posterior region does not require surgical repair. Actually, this is a Japanese professional pitcher, the famous pitcher. He has a big Posterior tear like this, And also this patient is a former Japanese professional. This patient played a former Japanese professional baseball league, and he went back to the United States, and he right now working in a major league baseball starter, but without surgery. So I think the most throwing athlete who has a extensive pastor does not require surgery. But after paid conservative treatment, if the infraspinatus function is okay, because the posterior cable remains intact, arthroscopic debridement indicated, no repair indicated, no repair is necessary. If the infraspinatus dysfunction is prominent due to the extensive pasta region, such as the posterior cable involvement, arthroscopic repair is indicated. So tear in pasta region is floors, tear progresses gradually, so the remains symptomatic even after proper physio. So if the patient demonstrates rotator cuff dysfunction, like external rotation loss or other strength weakness, they require physical repair. But for extensive pasta regions, normally we do takedown and repair. But takedown repair is very easy. But this study says that the Jimmy Andrews reported that the 12 professional pitchers, including 10 majors, he did mini open repair, takedown repair, and he said that the only one returned to pre-injury level, and the 3 retired to lower level, and 8 athletes retired. So this outcome was disastrous. So recently many surgeons prefer to do transtendon repair, like I demonstrated before the previous case. And I did the transtendon repair, but I operated 3 elite professional pitchers, and all of 3 returned to the minor league level, but they cannot return to the pre-injury level. So that's why still this kind of, even doing the transtendon repair, this is very difficult to have them back to the pre-injury level. So right now I'm doing is footprint lateralization using ultra small anchors. So normally this is an anatomical position, but instead of inserting the anchor to the anatomical position, I insert the anchor to the lateralized position of the footprint using ultra small suture anchor like this. So this is after pressing sutures like this. And then I tie the sutures in the bursa, and tie the sutures in the bursa. Then this is a final repair. So I think that this lateralized pasta repair, transtendon repair using ultra small suture anchors is the one potential. And in fact, Josh Dines from New York, he reported the 6 measuring pitchers underwent this procedure, and 5 returned to pre-injury level at least 1 full season, and a few pitchers resumed the pitching performance at their pre-operative level. And however, the possible mean number of innings pitched decreased remarkably. So they said the lateralized footprint repair affords a high rate of return to major league baseball play, but pitching productivity might decrease after surgery. So even doing like this is not 100%. So this is a posterior rotator cuff cable. Once again, let's look at the posterior rotator cuff cable. And this is a posterior rotator cuff cable here. And actually, from Current Job Clinic, Neil and his group reported that the posterior thickness tears involved in the rotator cuff cable, posterior rotator cable leads to abnormal glenomirral kinematics. So that's why the posterior cable repair for the extensive pasta region works in some major baseball pitchers. Actually, this is a personal communication with from near trash from current job clinic. So that actually, I think this is not proved yet, but I think this procedure may have potential for this kind of difficult situation. So many throwers who have deep and extensive pasta can pray without surgery, but throwers who require surgery do exist. So standard takedown repair may not work. So the footprint lateralization repair done in HSS and myself, and also the posterior cable only repair done in the current job clinic may have a potential in future. So to summarize my talk, bursal thickness tear, in a bursal side tear, symptoms strongly related to anterior cable involvement, and the anterior cable should be involved in the repair. And a pasta tear in the thorax, the posterior cable involvement related to infraspinous insufficiency and requires surgical repair. Thank you for your attention.
Thank you, Dr. Sugaya, for your impressive talk, as always. Thank you very much, and we wish you a happy and good days in your new clinic. I wish I can come to visit your clinic also.
Please.
Thank you very much. We have some questions. First, Tomo, we have two questions from the participants. First is from Taner Bekmezci. He asked about, is it possible to assume there is a crescent or there is a rotator cable in supraspinatus tendon due to anatomical findings?
Is it possible to assume there is a crescent or there is a rotator cable?
You can see from the question.
Yeah, is it possible to assume there is a crescent? He asked we could find rotator cable in the anatomical study.
I think he asked about your study that we can say that we can classify the rotator cuff tears. Before we always classify the tendon tears with the crescent shape or U shape or L shape. Is your study give some informations or give some new information about the classification? Can you talk about your study and the historical classifications?
I think classification does not change based on our anatomic study.
Okay.
Crescent shape, U shape. And also, I'm sorry to say that, but I think that in our study, rotator cable, I'm sorry, Dr. Sugaya, but in our anatomic study, we cannot find a rotator cable. But I think that, I believe that, I'm sorry, rotator cable is kind of linkle of the capsule. He also, Dr. Sugaya said, I believe that the anterior part of the posterior part of the capsule is thick. I agree with him. But I think rotator cable is kind of results of the degeneration of the capsule. You know what I mean?
Yeah.
It's my opinion.
Yeah.
Can I speak something?
Yes, of course.
Can I speak something?
Yeah, please.
Okay, I think that this question is maybe during anatomical study, can you identify the crescent, rotator crescent or rotator cable? That's his question, I think.
Yeah.
So I think the answer is no. Actually, I asked the formal and other anatomical group, where is the rotator cable? Where is the crescent? I asked them always, but they said no, nothing. There's no such structure. So that's why this rotator cable, rotator crescent is a kind of concept proposed by Steve Burkett. Many Americans believe this concept. So that's why when I present our anatomical study in front of the US doctors and European doctors, especially US doctors, always ask about that. What is the relationship of your study and the rotator cable concept? So that's why, based on our anatomical findings, and based on my clinical experience, and based on my conversation with US doctors, I summarize the relationship between our anatomical study and rotator cable concept in my talk. Understand?
Can I ask a question, Kerem?
Yes, please, Dr.
Tomo,
yes.
We read from the literature that the tear that begins posterior to the bicipital groove, 15 millimeters posterior to the bicipital groove, getting bigger and bigger. Mm-hmm. So according to your study, is it true or?
Yeah, it's true. It's true. Because between the insertion, tendon insertion of the supra and insertion, posterior margin of the insertion of the supra is about, I think, 10 millimeter, 8 millimeter or so. I think Dr. Mike Kim reported initiation side is posterior part, 10 millimeter posterior of bicipital groove. Yeah. It's the same portion, weakness portion. I think initiation of the rotator cuff start is Hiro said in his presentation between the insertion between the supra tendinous portion and supra and infra.
So normally the intramuscular tendon insertion of the supraspinatus remains intact.
Yeah, that's right. That's right. Most of more asymptomatic tear is intact. I think the anterior cable is intact. That's right.
Yeah,
I think so.
Yeah. Okay. We have more than 25 minutes for discussion, so we have so many questions. Second question is also about the tear classification from Mert Özenci. He asked about shall we change the rotator cuff tear classification because infraspinatus comes way anterior than it was thought before, he asked. And also the third question from Dr. Osman, what is the histological definition of delamination? Dr.
Can
These are for your, yes. For your...
I'm going to ask last question. Okay. I think the delamination, histologically, deep layer of delamination is mainly capsule. I insisted that I think I believe that deep layer is capsule. And we also examined the histological section of normal specimen. Even in normal specimen, we can recognize gap between the capsule and the tendon. So we believe that before rotator cuff start, delamination occurs between the capsule and the tendon. Do you know what I mean?
Yeah.
So I think histologically, deep layer of delamination, I believe capsule. Some believe that others don't believe.
You believe that we have to repair separately. First capsule and the delaminated tears, we have to repair separately, isn't it? Is that true?
Yeah, because capsule and tendon plays different function. Capsule is, I think, static stabilizer. Cuff is, mobile stabilizer. So I think it plays different role. So I believe that the different separate repair is better. But Dr. Sonho Kim in Korea compared these two groups. They are no different. So
in terms of stiffness, also,
I don't think so. No stiffness.
Okay, Dr. Ash has a question. I guess he raised her.
Thank you. My question is also to Dr. Tomo about the capsule. As your studies showed that the footprint of the capsule and the tendon is different, but in a not delaminated full thickness tear, we cannot identify during surgery which part is capsule and which part is the tendon. So we grab the tissue is supposed to be the tendon and try to pull it to the footprint. And maybe this may cause an extra stress on the capsule because there should be a capsular part of the tear. Right. What do you think about that? If the tear is not delaminated, how can we identify where is the capsule, where is the tendon?
I think that, yeah, mainly anterior part of the, the delamination. Dr. Tanaka, he was a fellow, reported most of delamination occurs the posterior part of the rotator lesion because based on our study, coracohumeral ligament is kind of coracohumeral ligament intermingle from rotator intercable between the capsule and the tendon. So anterior part is hard to it's hard to make in gap. On the other supraspinatus, it's easily to make delamination. So I think that my answer is that if we cannot find delamination in the rotator cuff lesion, I give up repairing separately. I repaired together. But I think the more the medium-sized tear, if you look at the posterior part of the torn lesion, you can find a deep layer in many cases.
Thank you.
Thank you, Tomo. We have two questions for Dr. Sugaya from Mehmet Kerem Canbora. He said hi to everyone. And how do you diagnose that complaints are caused by biceps or not in partial tears? In your clinical practice, does biceps pathology affect your surgical approach? The first question, Dr. Sugaya.
Yeah. Mm-hmm. What about the second question?
Second one is progression is different in partial tears. Recent studies, at least half of the intra-articular tears do not progress. Which patients do you approach conservatively?
So the partial thickness tear, when we talk about the partial thickness tear treatment, it is very important because symptoms, the responsible thing for the symptom must factorial, like a function, mirror head position relative to the glenoid, biceps, tear size, tear pattern, everything. So that's why I try to, first I do physio or maybe a pain control injection shot. If it works, okay, the pain came from here, this. Then, so, tear itself was mostly is not responsible. So that's why, I think the partial thickness tear, the essential region, essential factor in the partial thickness tear, symptomatic partial thickness tear is very, very difficult to diagnose. So that's why this kind of question comes. But on the other hand, foot thickness tear is very easy. The subscap tear is weak. And large tear, kind of clear. It's a clear impingement. We can diagnose that. But a partial thickness tear is much factorial, so that's very, very difficult. So that's why we need to everything: patient history, tear size, pattern, function, inflammation, everything. Biceps, of course, biceps. Everything.
Yeah. When do you do anterior cable repair or reconstruction? Do you anatomize or make a tenodesis if there is some problem in the bicipital groove or some pulley lesions? Do you tenotomize or do you make a tenodesis for the elongate of biceps if there's some problem?
What is kind of traumatic anterior cable tear in a young athlete, I try to preserve biceps. But in most cases, small foot thickness tears, sometimes degenerated partial thickness tear in 50s and 60s, I do biceps tenotomy or tenodesis in every case. So my only exception of the touching biceps is young patient, fresh injury, traumatic injury. I don't touch biceps. But mostly in the elder patient, 150, 60, and the degenerative tears, chronic tears, I do biceps. Mostly tenodesis or tenology.
Okay. The other question from Ahmet Huzeyfe Çetin. Do you think that ultrasound can replace MRI in middle-aged and older patients presenting with shoulder pain in the future, or the partial thickness tear?
That's a question to me?
Yes, please.
Okay. No, never. Because ultrasound can understand the, tear. Tear is present. What kind of tear? This kind of tear pattern and tear pattern, size, ultrasound can tell, but ultrasound cannot assess the muscle. So we need to assess the muscle itself, muscle as well, because we need to see muscles in order to know the chronicity of the tear. So the traumatic tear patient, atraumatic patient, acute on chronic injury, the assessing muscle is very, very important to decide the treatment strategy. So that's why ultrasound never can see the muscle. So that's why ultrasound is very convenient too. Actually, we're using that, but a final diagnosis can be made by MRI, including muscle assessment.
Okay, I have one question for Tomo. Tomo, do you think we have to consider to repair, in full thickness tears or massive tears, capsule and tendon separately, like Mihata? Dr. Mihata do SCR in capsular reconstruction, and he repaired the tendon as well. Do you believe that it works in such a cases?
I believe it works, but it's very it's very hard surgery. So I think all doctor cannot do that, but hopefully we should do that.
Yeah.
I believe.
Thank you. Dr. Arel has a question. Please, Arel.
I want to ask Dr. Sugaya. Dr. Sugaya, it's great to see you again here, and thank you very much for your great speech, and also congratulations your new clinic. And
thank you very much.
I want to ask your opinion. The intrasubstance partial tears, when you do the surgery, how can you decide take down and repair or just debridement? Do you use a bubble test or something?
But when I do, introtendinous tear, right? You mean?
Yes.
Introtendinous tear. My only indication of surgical repair for introtendinous tear is the involvement of the anterior cable, intramuscular tendon of the cerebrospinatus. That's the only indication. So the symptom is a little bit dramatic when compared with the other introtendinous tear. So that's a very clear, I think. So no bubble test, just the clinical findings and examinations and histories. That's it.
So if there is an intrasubstance tear for anterior cable, do you take down and repair always?
Yes, take down.
Take down.
Take down. I need to see the cable, the stump.
Right. Right. Thank you.
So many questions. Sorry about it, but we have time. 15 minutes more. So another question for Dr. Sugaya from Dr. Hakan Turan Çift, past fellow of Pascal Boileau. For sportsmen, he said, if we have two options, conservative or surgical treatment, we usually choose surgery for early return to sport. However, for pasta lesions, do you choose conservative treatment? And do you have any timetable for changing the surgical treatment, not insist on conservative treatment? He asked to Dr. Sugaya.
Pasta region is throwers?
Yes.
So the treatment in pasta region, throwers with pasta region is very, very difficult. The patient who has extensive pasta region is very, very difficult because surgery is not so reliable right now, like the Tommy John surgery for elbow. Tommy John surgery is very reliable. Maybe we can expect the more than 60–70% return rate within 2 years. But a pasta, it takes long time, and also return rate is very low. So that's why I think maybe many American doctors are very reluctant to do surgery for pasta region, but instead they love to do Tommy John surgery. So that's why the number of cases increasing. So the baseball throwers, pasta is very difficult. So my indication of pasta repair is infraspinatus insufficiency. As I spoke in my lecture, infraspinatus insufficiency becomes present when posterior cable disrupted. So before posterior cable, if the posterior cable is intact, normally their function is good, acceptable. The physio works very well. So that's why that's the indication. So in that sense, my indication is very clear.
Another question from Mert Erzenci. He said, in pasta lesion, Dr. Sugaya prefers to repair transtendinous, not taking down. But how about the capsular injury and blood vessels coming from the capsule also injured? He said.
So actually, I was doing the takedown repair before, but that was not successful. So that's why I changed my technique to the intertendinous, transtendinous repair. So I think based on the anatomical study Tomo presented, by doing transtendinous repair, I repair only capsule. I grab the capsule to reattach the capsule to the little bit more lateral position of the footprint.
Okay. Another participants asked about the stiffness. Murat Kayalar, Dr. Murat Kayalar from Izmir. What is your comment on the relation between stiff shoulders and partial tears?
So normally, I reported back in 2015. We reported 2015 to the JBJS the rotator cuff regions in the stiff shoulder, and we found that the 90%, the severe and global, we classified the stiffness grade, severe and global loss. And we found the severe and global loss patient, and we found only 10% has a partial thickness tear, and 90% their rotator cuff was intact. On the other hand, the less severe global loss patient, the rate of the having thickness rotator cuff tear is increasing 40–50%. So that's why the patient with partial thickness stiffness associated with partial thickness tear. So normally patient stiffness is very severe and global. So that's why for such patient, if surgery is indicated, I do just capsular release, 360 capsular release. I don't touch cuff. Because I think these patients are responsible, capsular is responsible for the symptom, not cuff.
Yeah. Another question from Mehmet Demirhan, the former SESEC president. He said, hello to Dr. Sugaya and Dr. Tomo. He said in Seoul 5 years ago, he met you, Dr. Sugaya, in Seoul.
Yes.
He said, hello, personally. So Mehmet Demirhan has had a publication about not the separate layers transosseous equivalent repair of delaminated rotator cuff tears in 2019, and he asked about this concept. Do you believe is it necessary repair separately that we already discussed, Dr. Sugaya? Do you believe that we have to repair separately?
Actually, I was repairing separately before, but right now, repair together. Because, the capsule, as Thomas said, capsule and calf is different structure. And also, just different in a more proximal portion. function is different, appearance is different. But the most distal insertion area is very difficult to distinguish these two structures because they are, the shoulder without delamination, it's very difficult to distinguish these two structures. So that's why I think an important thing is deep layer should be repaired to the medial side of the footprint. Instead, superficial layer repaired to the lateral side of the footprint. So I don't care, repair together or repair separately.
Dr. Armangil, Mehmet Armangil has a question about the orthobiologics and biological healing augmentation. For example, microfracture, bone marrow venting procedure. Is it working? Does it work in the partial thickness rotator cuff tears repairs? We can ask to Tomo. Tomo has so many experience about the orthobiologics or mesenchymal stem cells.
Yeah, I think that Dr. Yamakado in Japan reported for the partial repair and also bone. I'm sorry, bone. How can I say that?
Microfracture, you mean?
I'm sorry. Partial repair and microfracture. He reported it works very well. After 1 year or 2 year MRI, it looks like complete repair. So I think that microfracture will work. I believe that.
We also published 5 years ago an experimental and clinical study about it, but we publish it on the full thickness tears, chronic and retracted tears on animal models. Also Yoshikida from Kyoto published an experimental study about it, and he showed the bone marrow cells going into the tendon. He showed it with an excellent experimental study, Yoshikida. He's my good friend. Yeah. Another question for Dr. Sugaya from Tahsin Beyzadeoğlu. When do you consider surgery for an elite throwing athlete with glenomirral internal rotation deficit? He asked about the gear. Yeah.
So the throwing acid glenomirral internal rotation deficit seen in most throwing athletes. So, regardless of symptomatic or asymptomatic. So that's why this kind of patient, first we try to control remove the internal rotation deficit. Actually, internal rotation deficit, many doctors said that there was posterior tightness, muscle tightness, capsule tightness. But recently I found that there's the real tightness patient who has real tightness is the number is very small. Actually, their position of human hair relative to the glenoid is little front, little translated. Then if we reduce that, then automatically the deficit disappears. So that's why I don't operate the throwing athlete only for the internal rotation deficit, based on the symptom and the function and everything.
Okay. Another question from Serdar Kamil Chepni. He said, Dr. Sugaya, when you consider the partial article tears, when you go conservatively, does it indirectly facilitate biceps pulley pathology and subscapularis tear? When we go conservatively, it can progress. He asked.
It's maybe possible.
Yeah.
Maybe possible, but I don't care.
Yeah.
So I only see the symptom.
Yeah.
So when the patient became symptomatic and presented the biceps problem, bicep histology, and the rotator subscap. Then we do something. I do something.
Okay. Do you use in your clinic the orthobiologics, Dr. Sugaya, like PRP or other orthobiologics?
We're gonna start doing that. We're gonna start doing that. Now I'm free. I'm free to decide everything.
Do you think it works in partial tears, partial thickness tears?
I don't think so.
You don't have any evidence.
No, no evidence.
Yeah. We need some studies about it.
Yeah.
Definitely. And the last question, we have 5 minutes more, maybe. How do you effectively assess intraoperatively the site of a partial tear and the quality of the remaining intact tendon to help your decision for the repair in situ or tear completion? How do you decide the size, the percentage?
I do, actually, I assess the intraoperatively also, but I do, my assessment is basically almost in a preoperatively, like a patient age and background, the history of the shoulder symptom and the chronicity of the tear. So then, in the Rotator MRI findings, then I do complete or transtendon repair. I decide preoperatively, and during surgery I confirm that.
Yeah. Okay. Maybe 2 more questions. One is about the acromioplasty.
Mm-hmm.
We can ask both of you. Do you do acromioplasty for your repairs? Do you do anterior or lateral acromioplasty, especially in bursal site tears? Tomo, do you use acromioplasty?
Basically, no. But the spur, anterior spur is big. I'm gonna remove the anterior, just anterior part.
You don't make any lateral acromioplasty?
No.
No. You, Dr. Sugaya, do you do acromioplasty?
Actually, I basically do acromioplasty at the same time, but my acromioplasty is getting less aggressive every. So basically, I just remove spurs in the front, anterior side, and also the AC joint side, and also lateral side, and also the obtaining clear view of the bursa.
Okay.
So the spur number 1 is spur removal. Number 2 is obtaining clear view. That's a reason of doing acromioplasty.
Okay. Okay. The last question maybe. You know the CSA, the critical shoulder angle, has a relation between the bursal site tears. When it is more than 25 or 30, the cuff tear became more frequent. So is there any risk or anatomic parameters for pasta tears? I mean, intra-articularly anatomic impingements in between the glenoid and the greater tuberosity. Do you have any idea, or do you have any landmarks or measurement like CSA for the internal impingement, Dr. Sugaya?
No, for pasta.
Yeah.
Sorry.
Maybe it's another. Yeah, maybe we can make a study about it, but we need data and measurements. Mm-hmm. We have to think about it. Thank you. Yeah. Thank you to Tomo, to Dr. Professor Sugaya for your valuable and impressive talks. You gave us a lot. Thank you for your contribution, as always. And I would like to finish the webinar maybe Mustafa Özkan, our president, will finish this session.
I want to thank all of you for your detailed presentations and your contribution to our webinar. I think on the other webinars, we will also invite you again, invite two of you again, I think. Thank you very much.
Thank you very much.
Thank you very much.
Have a nice.
Thank you, sir.
Thank you.
Bye.
Thank you.
See you soon.
Personally.
See you in person in future.
See you in Turkey.
Bye-bye.
Bye-bye.
Bye-bye.
Bye.